Good afternoon, everybody, and thank you so much for joining us. We're excited today to have some wonderful speakers present on a very interesting topic. I'll jump right in. My name is Heather Lannon. I work at the Center for Living Organ Donation here at Toronto General Hospital. And we're delighted to have two speakers today from just across the street, as we like to say here. They work in the Anthony Lab at Sick Kids Hospital. We have Sarah Pohl and Gia Lynn, who is going to present on some of the work that's being done at the Anthony Lab. As you can see on your screen, the title of today's presentation is The Complexity of Creating a Culture of Organ Donation and Transplantation. And they will take you through the presentation. Then we're gonna allow maybe 10 or 15 minutes at the end for some Q&A. So if you want to participate in the Q&A, our Slido account is open. So please go to slido.com and use the code organ donor. It's all one word. So put that code in and you can certainly pop a question there into the Slido and we can hopefully get to them at the end of the presentation. So I'm going to hand it over to my colleagues. Gia and Sarah, if you want to introduce yourself a little bit more or just take it away, that's totally up to you. But looking forward to hearing this.
Thank you very much, Heather, and thank you for having us. My name is Sarah Pohl, and I'm a clinical research project coordinator at the Hospital for Sick Children in the Anthony Lab. And I'm here with Jai.
Hi, everyone. My name is Jai, and I'm also a clinical research project coordinator working at the Anthony Lab at Sick Kids.
And the title of our presentation today is The Complexity of Creating a Culture of Organ Donation and Transplantation. And we have no conflicts of interest to disclose. We want to begin with an acknowledgement of the land, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. And we say this land acknowledgement respectfully to acknowledge the rich Indigenous governance that have existed, as well that are ongoing, and that will continue into the future. And for us, this acknowledgement reminds us that we are accountable to our relationships with diverse nations, and that many of us as settlers continue to benefit from this land that we live, play, learn, and work on.
These are today's objectives. We will be presenting the aims of our lab's organ donation and transplantation research program. We'll then move to illustrating key findings and next steps of our qualitative research projects, including family veto, crowdfunding, and health equity. And then we'll move to a discussion around the complexity and intersections of individual, interpersonal, and structural factors surrounding organ donation and transplantation. And as qualitative researchers, we feel that it's important to speak a little bit first about who we are and our positionalities. So me, myself, I'm female, Chinese Canadian, cisgender, straight, and able-bodied. I grew up in Toronto my whole life, and this is a place I call home. I'm also educated with a background in sociology and public health. I have never experienced organ donation or transplantation, nor do I know anyone closely has gone through that experience. And lastly, I am a researcher, not a healthcare professional.
And I am female with a Dutch background, cisgender, straight, able-bodied. I grew up in London, Ontario, and I am master's prepared with a background in health sciences, anthropology, and global health. I don't have any personal experience, nor do I know anyone personally who has experience with organ donation or transplantation. And I'm a researcher, not a healthcare professional. And we're saying this because we believe that our social location, our background knowledge, our area of study, personal values, really frame our research approaches, as well as how we interpret the data that is collected. And this awareness of our place in social cultural context allows us to interrogate our own biases and to prevent reinforcing existing privileges. And we think that it's important not only for qualitative research, but especially for equity-oriented health research. the program of research in the Antonia Lab. One of the components of our team's program is to investigate variables that are critical to successful organ donation and transplantation. And it's this aspect of the program of research that Jai and I will be discussing today.
And the projects that we'll be illustrating today are mainly qualitative in nature, and we utilize qualitative methodologies to listen to participants' voices and prioritize the expertise of their lived experiences, to learn how participants construct their world in relation to organ donation, and to understand the meaning participants ascribe to their illness experience.
So thinking about the question that we're really exploring in the presentation today. And that question is, what are the various considerations for successful organ transplantation? And as you'll note, we also included a puzzle piece on this screen, which we feel is really representative of this complexity of the different layers and variables involved in our studies. And we'll now start that presentation, and Jai will begin by presenting the Family Veto study.
So the first study we're going to be talking about is titled Family Veto in Organ Donation, the Experiences of Organ and Tissue Donation Coordinators in Ontario. And the objective of this study was to examine the experiences of organ and tissue donation coordinators who work with substitute decision makers who vetoed a deceased donor's legal consent for organ donation. And this study was conducted in collaboration with Ms. Linda Wright from the University of Toronto, as well as Dr. Sunny Dhanani, who is a critical care physician at CHIO. And we'd like to thank Trillium Gift of Life Network and the Canadian Donation and Transplantation Research Program for their support with this project. A little bit of background around Family Veto. The supply and donation of organ and tissues remains the most persistent problem in the field of transplantation. In 2019, there were over 4,300 Canadians awaiting an organ donation, of whom 249 individuals died on the waiting list. So this is a critical issue limiting the widespread implementation and effectiveness of transplantation. In Ontario, organ donation registration is a free and voluntary process available to all residents aged 16 years and older, and registration for organ donation is legally valid consent following death. In most cases following a death, when substitute decision makers or families are approached to reaffirm the deceased patient's registration and consent to donate their organs and tissues, families honor the wishes of the deceased patient. However, family veto occurs when the deceased patient's family overrides or vetoes their wish to donate their organs. And this evokes a legal and ethical tension between respect for the previously expressed wishes of the deceased patient and the current wishes of the family. So according to Trillium Gift of Life Network, family veto occurs in around 15 to 20% of registered approaches for organ donation in Ontario, and one organ donor can save up to 8 lives. So in 2019, 2020, there were 72 family vetoes representing a loss of up to 250 potential transplant opportunities. So our lab conducted a media analysis on the framing of family veto within English language newspaper articles in Canada. And this article was published in CMAJ Open. And the findings indicated that family veto was framed predominantly in news media as something that should not be allowed, so 61%. For example, family veto was characterized as terribly wrong, a shame, and tragic. And one article wrote, a family shouldn't be able to override a person's decision to donate organs at the time of death if they signed a card. That is like saying a dead person's will is not valid and a family can disperse belongings as they wish. Family veto is also framed as something that is little understood outside of the organ donation transplantation community, with many articles erroneously stating or implying that existing legislation permits family veto. So this slide is an overview of some of the key stakeholders involved and impacted by family veto. We have the deceased donor who consented legally to donate their organs and tissues for transplantation, the substitute decision maker who vetoes the deceased donor's consent for organ donation, There are also healthcare providers involved, such as critical care physicians, nurses, and allied health professionals who care for the deceased patient and who will refer patients and families to donation coordinators to initiate the organ donation conversation. And we have organ and tissue donation coordinators who facilitate the organ donation process. And some of their professional responsibilities include identifying potential donors, approaching families and introducing organ donation, and then following up with families after organ retrieval. And this schematic isn't a comprehensive list of all the players impacted by Family Veto. Family Veto also impacts potential transplant recipients, their families, the healthcare system, and also the larger organ donation and transplantation community. But this really demonstrates the legal and ethical tension that involves so many different stakeholders, in particular the respect for the previously expressed wishes of the deceased donor and the current wishes of the substitute decision maker. And also donation coordinators really work at the nexus of this phenomenon. And so we wanted to explore their experiences with Family Veto. Our methods, we utilize a qualitative interpretative phenomenology approach, which is a systematic inquiry into the lived experiences and meaning-making activities of participants relating to a phenomenon. So in this case, the phenomenon being Family Veto. We employed semi-structured focus groups with organ and tissue donation coordinators from Trillium Gift of Life Network. And participants were included if they were working as a donation coordinator for a minimum of 6 months and self-reported experience with Family Veto. We conducted 2 focus groups with 10 organ and tissue donation coordinators, and a hermeneutic interpretative process of analysis informed our data analysis. So this consisted of independent descriptions of participants' experiences with Family Veto, which was then shared and compared within the research study team, and themes emerged and were refined through collaborative and reflexive engagement. So 4 themes emerged from data analysis. The first theme is titled The Significance of the Organ and Tissue Donation Coordinator Role. And this was highlighted as donation coordinators reflected upon being advocates and educators in their role. Many donation coordinators emphasize their responsibility to advocate for the wishes of the deceased patient when introducing organ donation to families. One participant said, "We're honoring the patient's decision. Yes, it's hard for the families and we're here to support them through that process, and that's our role. We are advocating first and foremost for the patient always." Participants also frequently became educators to families, which is important to dispel any myths around organ donation. Another participant said, "Sometimes families ask about open casket. We address it, that organ donation doesn't affect open casket viewing." And overall, donation coordinators expressed a profound sense of fulfillment in engaging with families, highlighting a sense of job satisfaction. So one participant said, "Case of the families are great, and they get inside your head and they stay with you, and it's an honor to be with them." Our next theme is titled Emotional Distress and the Understandable Family Veto. And as donation coordinators reflected upon their experience with the Family Veto, a lingering sense of emotional distress became present. One participant said, "You sort of feel like one time when Family Veto happened, I just cried. I called my manager because I felt really sad about the situation. The donor was registered and he had lungs." And this quote here really emphasizes the sense of distress and almost failure tied to the deceased patient, and the inability to honor their consent to donate. And we found that emotional distress was often heightened in situations when families were unwavering in their decision to veto. However, the concept of an understandable veto also emerged from analysis where donation coordinators acknowledged the situational factors influencing family decision-making, such as trauma or the sudden death of a loved one. One participant said, "Every time I do get a family veto, it's because of a traumatic experience where I understand why they are vetoing the decision." And in these cases, donation coordinators understood the family veto because of these situational factors and that they had done everything possible in their role to support the deceased patient. Donation coordinators also identified several barriers that challenged organ donation, contributing to family veto. Timing was a significant barrier. Organ donation is a time-sensitive process demanding timely identification and referral of potential donors and timely initiation of the donation conversation with families. So donation coordinators discussed how limited time and the prolonged donation process impacted decision-making around authorization. One participant said, substitute decision makers are in support of it, but as soon as you start exploring how long this is going to take on top of what they've already been through, they just want to get from where they are to the endpoint very, very quickly. Coordinators also identified a perceived ambivalence from healthcare providers towards organ donation, in that they were sometimes less enthusiastic to make referrals, and donation coordinators attributed this ambivalence to rare but influential past negative experiences caring for transplant recipients. So another participant said, it's really tough. A lot of the nurses who care for the transplant patients that don't do well, they're really jaded. A lot of them, they only see the bad stuff, and when it's bad, it's really ugly. So our last theme is titled Strategies Towards a Culture of Organ Donation. And donation coordinators identified several strategies. Many donation coordinators cited using value positive language, which emphasizes the deceased donor's desire and intention to donate when communicating with families. So when participants described, we'll use the wording, we can honor their wish, we know this is their wish, they're registered, and they've obviously put a lot of thought into this. There were also many calls for increased public education around organ donation and transplantation, as there was a lot of misinformation concerning the process of organ donation. So one participant said, like in Grey's Anatomy, the episode's done in an hour. It makes it hard to kind of argue because that's probably the public's perception of it. And then lastly, donation coordinators spoke about the need for open conversations around end-of-life wishes and really mainstreaming these conversations into everyday life. So one participant said, have a conversation at your family doctor, have a talk in school when they're all in grade 12. They need to know you got to be on a ventilator. They need to know these things. And a culture of organ donation could prepare families to anticipate the donation conversation, and also could support their grieving and healing process for the deceased patient. So a few key takeaways from the study. Family veto represents a legal and ethical conflict that places healthcare providers and donation coordinators in a difficult position. Our findings of increased distress among donation coordinators during a family veto highlights this ethical and moral conflict. And donation coordinators were conscious of the morally appropriate action for the deceased patient, but could not carry out that action because of the family veto or other barriers that challenged their action. Our findings also highlight important considerations around organ donation authorization processes, specifically around waiting times for families, potential donors, and the need for enhanced organ donation public education. And there is a clear need for collaboration with all stakeholders to align healthcare practices, donation policies, and educational initiatives to reduce family veto, increase organ donation, but also to honor the wishes of the deceased patient. So we're super happy to say that our study was recently published earlier this year in the Canadian Journal of Anesthesia. And alongside this publication was also an editorial titled Much Ado About the Family Veto. This editorial highlighted many of the ethical considerations surrounding family veto, especially the importance of patient autonomy. When an individual takes the time to register their consent to donate their organs, healthcare providers have an ethical duty to care for the patient and respect their wish. So in this context, the editorial makes a point that family distress alone can be insufficient to override the patient's wishes. And the editorial makes several recommendations to improve organ and tissue donation processes, one of which surrounds the ask when introducing donation to families. So rather than asking, donation coordinators should inform families that the patient is registered and will donate their organs. And this is being seen in practice today. So with that, I'm going to pass it now to Sarah, who is going to be speaking on our crowdfunding and health equity studies.
So the title of the next project, which we'd like to discuss, is Tremendous Financial Burden, Crowdfunding for Organ Transplantation Costs in Canada. And on this project, we collaborated with Dr. Jeremy Snyder from Simon Fraser University in BC. And the objective was to better understand why Canadians use crowdfunding, what needs are not being met in relation to kidney and liver transplantation in particular. From this next slide, you'll notice that the costs associated with organ transplantation have been a topic in Canadian media. And notably, the articles often are sharing the patient perspective, with headlines reading, "You want to scream, the cost of organ transplant a worry for some BC patients." This double lung transplant survivor wants to see more financial support for Newfoundland and Labrador recipients. They face financial ruin to get a new lung. Some are choosing to die instead. Medical crowdfunding is a rapidly growing practice whereby campaigners use online platforms to raise money for health-related needs via social networks. Countries with robust public insurance systems like Canada and the United Kingdom see substantial numbers of medical crowdfunding campaigns, which highlights many inequities. Within the context of organ transplantation, geographic inequities can exist as individuals are required to live in a city where the transplant center is located, which are often urban centers like Toronto. This, while donor, candidate, recipient, or caregiver is also tending to expenses at their home and likely experiencing an income loss. This also ties to socioeconomic status. Does the donor, candidate, or caregiver have a stable job, insurance, or benefits? Do they have a flexible employer who is understanding? It's important to be mindful of social capital and social networks as well, as recipients need to have a caregiver identified in order to be placed on the transplant list. In terms of methods, we conducted an internal search on GoFundMe to identify campaigns related to kidney and liver transplantation. And originally, 640 kidney campaigns and 499 liver campaigns were yielded. The inclusion criteria required that the campaign recipient resided in Canada and that the campaign was raising funds related to kidney or liver transplantation, and those funds were understood as either direct or indirect needs prior to, during, and or following the transplantation. Campaigns not meeting this criteria were eliminated, which resulted in 258 and 171 liver campaigns. The team met regularly during the coding process, and we coded or captured a variety of different information. But today I will be presenting data collected around whether or not the campaign recipient was an adult patient, language around recipients' worthiness for receiving donations, and also how any money donated to the recipient would be used. Beginning with some descriptive results here. Kidney campaigns received 11.5% of requested funds, in contrast to liver campaigns, which received 49.1% of requested funds. And interestingly, liver campaigns received more Facebook shares as well, and also more donations on average than kidney campaigns. So on average, liver campaigns receiving a little over 8,000 versus kidney campaigns, which received on average just under 4,000. When looking at who campaign recipients were, there were more campaigns for adult recipients as opposed to pediatric recipients. However, interestingly, pediatric recipients received a greater percentage of requested funds. And this was something that was consistent across both organ groups. So in the case of liver campaigns, for example, pediatric recipients receiving 60% of requested funds, compared to adult recipients receiving 42.2%. Similarly, similar pattern being seen in campaigns for kidney transplant, pediatric recipients receiving 37.1%, adult recipients receiving 10.6%. Looking now at how campaign writers were framing the recipient, how they were describing the recipient. And it's important to note that sometimes the campaign writer was the recipient of the GoFundMe, and other times the campaign was written by someone else on behalf of the recipient of the campaign. So the most common framing of worthiness among both organ groups was that the recipient was someone who was an amazing person. They were caring, they were lovable, they were kind. So an example from a kidney campaign. 12 years ago, my son-in-law was given a kidney. Since that time, he's continued to work and provide for his family despite the many health setbacks he has had. From a liver campaign, I'm writing this on behalf of an amazing, caring person who's been giving everything and more to her family, friends, and everyone around her. Second most common was that it was quite uncharacteristic of the recipient to be asking for money or to even be asking for help. From a kidney campaign, she's not one to ask for help. It makes her uncomfortable and ashamed. From a liver campaign, she's the type of person who would never ask for help from anyone. The third most common was that the recipient had looked into other ways of being able to raise money or other ways of being able to cover expenses. From a kidney campaign, with a chronic medical condition, disability insurance is not an option. From a liver campaign, the reason the family has chosen this avenue is that he no longer qualifies for any kind of disability benefit after receiving the new liver. And then lastly, some campaigns were also mentioning that the recipient themselves had made positive changes in their life as a way of kind of advocating for this worthiness, that they were worthy of receiving donations. So from a kidney campaign, we worked to slow down the deterioration of his kidney function with diet and medication, but 3 years ago, he had to go on dialysis. From a liver campaign, he challenges those around him to act and live in the best way they're capable of. He also takes action himself. He's been sober and stable for a long time and now gives back to others daily. Now looking at the proposed use of any money donated, almost even the objective of the campaign itself. So the first most common for kidney campaigns was that the money would be used for patient living expenses. And this was within kidney campaigns, more than half identified this as an objective of crowdfunding and how any money would be utilized. And the same objective, again, being money being used for patient living expenses, was third most common for liver campaigns. Both organ types had kind of the same objective for the second most common reason, which was patient relocation, things including travel and rent. Third most common for kidney campaigns was having to do with loss of income, specifically for the patient. And interestingly, the first most common for liver campaigns was around caregiver expenses. And notably, kind of looking at these top three reasons, top three objectives, this was the only objective mentioning caregiver expenses. In conclusion, this represents a health inequity, and it's not, there isn't equitable access to crowdfunding. And crowdfunding really comes at a cost to privacy of the individual creating the account, also, or creating the campaign rather, also the privacy of the individual who is the recipient of the campaign, in order to kind of portray a story or to share information that would make the recipient appear credible. This is a band-aid solution that works for some and often actually increases the health inequity. What is needed more so to address the gaps is policy change as opposed to this type of crowdfunding. And this research project was picked up by a reporter at the National Post, and an article was published on the front page in January of 2020, and the title of the article is "Where a Liver Outperforms a Kidney." And of course, this is in reference to the fact that campaigns related to liver transplantation received more funds than campaigns related to kidney transplantation. Our work was also published in December of 2019 in the Public Library of Science 1. The next study that I'd like to talk about is our health equity study, one of them rather, and the title of this presentation is "Improving Health Equity, Increasing Access to Living Donor Kidney Transplantation Among Chinese Canadians." And on this project, we're working with Dr. Ishvan Mushi at UHN, as well as some other institutions and community collaborators. And we're interested in exploring the perceptions and knowledge of living donor kidney transplantation among Chinese Canadians and what they perceive as barriers and facilitators to accessing a living donor kidney transplant. And we'd like to acknowledge the Kidney Foundation of Canada for funding this project. And most recently, we're very excited that funding for the second year of this study has been confirmed. So very excited to be moving forward with this project as well. Just to start off with a little bit of definitions here. So equality, and the meaning of equality is really focusing on creating the same starting line for everyone. So in the image here, we see that everyone has the same crate. Some are able to see the game, some are not. The gap still persists in height. And in the context of kidney transplantation, if we're trying to apply kind of a similar idea here, generally speaking, everyone can receive care at the hospital, when they have chronic kidney disease. So with equality, again, the gaps between different individuals remain because everyone is treated the same. Equity, however, is focusing really on the end goal and having everyone at the same finish line. So you'll see here different individuals have different amounts of crates, whether they need a crate or not, in order to be able to see the game and to have kind of that same access. So in the context of kidney transplantation, everyone receives a kidney no matter their ethnocultural group. Again, recognizing that some experience more burden than others and trying to reduce this burden. Research in Canada conducted by our team and others determined that East Asian Canadians were less likely to receive a transplant compared to white Canadians. And importantly, this inequity was most profound for access to living donor kidney transplant. In further research examining this association between ethnicity and having a potential living donor identified, Asian Canadians have a 30 to 60% lower odds compared to white Canadians at the time of first assessment for kidney transplant. And this is concerning as patients who do not have a potential living donor identified at the time of referral were subsequently less likely to receive a living donor kidney transplant at a later date. Our methods of study to be exploring some of the perceptions are to conduct individual interviews, and we'll be exploring the perspectives specifically of 5 participant groups. First group being Chinese Canadian patients with chronic kidney disease. Second group being caregivers of Chinese Canadian patients with chronic kidney disease. Third, Chinese Canadian living donor kidney transplant recipients. Fourth, Chinese Canadian prospective and potential living kidney donors. And finally, fifth, Chinese Canadians who are not impacted by chronic kidney disease. Specifically at Sick Kids, we'll be recruiting for the caregiver population, so the second one there in the blue font. And interviews will be individual, they'll be semi-structured, virtual as well. We're hoping to recruit about 10 participants per participant population, so roughly about 50 participants for the entire study as a whole. And we are prepared to conduct some interviews in Mandarin or Cantonese. In terms of data analysis will be informed by a qualitative content analysis, which is the interpretation of the content of text data through the systematic classification process of coding and identifying themes or patterns. And together, all team members involved within this data analysis process will meet regularly in order to review and refine the codes and identify emerging themes as well. Where we're at with this project now is that our team is in the process of finalizing our interview guide, and we're doing this by conducting mock interviews with members of the Chinese Canadian community in order to pilot the questions. And this step is really important because it exposes key practical issues and also provides an opportunity to address and resolve concerns that might other hinder data collection. So for example, a stakeholder shared that providing a situational example and then kind of asking questions specific to that situation might be more effective than trying to explore participant perspectives. We also learned that it might not be culturally appropriate to use the word deceased within the interview and kind of in probing questions or even in initial questions as well. This type of pilot work also serves as a means of training the research team to conduct culturally competent, culturally appropriate, and meaningful data collection activities. And we have also begun recruiting patient and caregiver participants. So here we are, we've returned to the idea of the puzzle piece as representing the complexity of creating a culture for organ donation and transplantation. And one of these puzzle pieces could be seen as understanding the organ donation process. So that idea relating to our family veto project. Also, substitute decision makers authorizing to donate deceased individuals' organs, again relating to our family veto project. The idea of being able to afford to have a transplant closely ties in with our crowdfunding project. And then also the importance of having health information that is accessible to different cultural groups, and also even cultural acceptance of organ donation and transplantation. And both of those ideas are puzzle pieces tying closely to our health equity project. And each study has allowed us to kind of explore these complexities and different barriers in the organ donation and transplantation process. And as I'm sure you can imagine, it's based on kind of the puzzle piece analogy as well. It's not an easily marked path or clear path like we see in this photo here. It's definitely more complex.
So with that, I'm gonna start a discussion a little bit about the individual, interpersonal, and structural factors around creating a culture of organ donation and transplantation. And we've really organized some of the key considerations that have emerged from our research projects within the socio-ecological model, which investigates and interrogates the dynamic interrelations among various individual, interpersonal, and structural factors. And the idea behind the systems level theory is that a successful organ donation and subsequent transplantation does not occur in a vacuum. It's not fully possible to understand organ donation transplantation without taking account these various factors. So this slide represents the key individual factors that have emerged from our research. Starting with the transplant stage, our studies, family veto, and crowdfunding highlight the waiting aspect for an organ from a donor. In order for a successful transplantation, there needs to be a viable organ donated. And we see in our health equity project that certain ethno-cultural groups may be less willing to ask or receive a living kidney donor. And we also see in family veto that a potential donation wish counter to legal consent can be vetoed. Moving to living versus deceased donation, our family veto and health equity studies highlight the different considerations of asking for a donation, whether you're able to find a viable match or being on the waiting list for a deceased donation. And in Canada, around 80% of transplants are from deceased donors. However, living donations are preferred for kidney and liver transplants due to improved health outcomes following transplantation. And this year also highlights some of the differences for the organs, because for some organs, such as hearts and lungs, the only option is to wait for a deceased donation. And this contextualizes some of the distress that stakeholders felt when a family veto occurred, especially with functioning hearts or lungs. Moving to donor versus recipient, all three of our projects, we've highlighted the different perspectives of being a donor and wanting to donate, as in family veto, but also being on the other end of the spectrum as a recipient and that waiting aspect. The age of the recipient is another individual factor. The crowdfunding study emphasized the impact of age and the differences in amounts of funds raised between pediatric and adult recipients. So while children had less crowdfunding campaigns, they received a higher percentage of their requested funding. And this could speak to the idea of fair innings, or that children having more of their life ahead of them. Moving to social capital, crowdfunding and health equity studies highlighted how interpersonal relations can really impact an individual finding a living donor, having a caregiver present during the transplantation process. And furthermore, if a potential recipient is crowdfunding, social capital could impact the willingness and amount of donations received from their social network. And lastly, financial capital. The crowdfunding study highlighted the critical considerations of socioeconomic status and the barriers for those individuals who cannot pay for the additional expenses relating to transplantation, such as relocation and the potential loss of employment. So moving on to the second layer of our model, interpersonal and community factors or gatekeepers. Our projects really bring to light the importance of collaboration, negotiation, and shared priority setting needed between our key stakeholders to support successful organ donation and transplantation. In our family veto study, we describe how even after an individual has registered their consent to donate their organs, their families or substitute decision maker can still veto this consent. And while research is still quite preliminary in this area in terms of the perspectives of families, our colleagues at the Ottawa Hospital have suggested that families have informational needs regarding the organ donation process. And trying to understand what happened to a loved one after sudden death can be quite challenging, impacting their decision-making and authorization around donation. Our family veto study also revealed the important role of healthcare providers and how a perceived ambivalence towards organ donation impact the organ donation process. So some research investigating healthcare providers have suggested that the most common reasons for physician non-referral and organ donation include an assumption that the transplantation would be unsuccessful, concerns that they might get sued if they removed organs without family consent, and also not wanting to cause the family any further harm. On the other hand, we saw donation coordinators negotiating with healthcare providers using language such as value positive language to kind of further or respect the patient autonomy. And then lastly, we have the role of cultural and community leaders who are also important drivers of disseminating knowledge and information around organ donation and transplantation. Cultural and community leaders are key players in health promotion strategies. They can frame public opinion and discourse around donation. And so in our health equity study, we are engaging with Chinese Canadian community leaders across Ontario for their important insight throughout our research process. And lastly, structural forces, which are of course embedded within our society. Culture and cultural acceptability of organ donation and transplantation is an important structural factor. For example, things getting lost in translation, a mistrust of the healthcare system because of racism. And so our health equity study around living kidney donation among the Chinese Canadian community really is rooted in this idea and concept of cultural competency within the delivery of healthcare and the need to tailor practices for different ethnocultural groups and their needs. Policy gaps in the healthcare system is another structural factor, and we see in our crowdfunding study, unfunded pharmaceuticals and lack of access to transplant centers in rural settings really illustrates the additional patient-borne expenses associated with transplantation. And while our Canadian healthcare system is comprehensive, accessible, universal, portable, and publicly administered according to the Canada Health Act, there are certain groups that are more vulnerable to fall within these gaps due to the social determinants of health. And so while initiatives such as online crowdfunding may alleviate some of the financial barriers, they really do also take away some of the responsibility and accountability from our healthcare systems and our more downstream band-aid solutions. So larger conversations around how we can address these policy gaps are needed. Public perceptions around organ donation transplantation is another structural factor, and consent for organ donation does depend on public support and their willingness to donate. And a recent survey from the Canadian Transplant Society found that while 90% of Canadians support organ donation, only about 20% were actual registered donors. So this not only speaks to the need for more organ donation registration initiatives, but also thinking about our family veto study, how we need conversations with family members and friends following registration to help indicate one's strength and intention to register or their wish to register to donate. And lastly, education, which is also tied to public perception. In the Family Veto study, donation coordinators suggested increased education to raise awareness of these issues and also really mainstreaming donation and end-of-life wishes into our everyday conversations. We are seeing some of these initiatives today. For example, the high school outreach initiative at Sick Kids was launched by some staff members in 2011. And so this initiative involves classroom presentations delivered by a transplant healthcare professional and a transplant recipient, where they visit high schools across the GTA to talk directly with students about organ donation and transplantation. And students are further encouraged to continue these conversations with their family and friends and share what they've learned through these interactions. So overall, each of our projects has really enabled our team to investigate these different barriers and key factors and layers for organ donation and transplantation at these different levels. And these are really key areas to target for developing interventions, policy recommendations, and practice guidelines in Ontario and across Canada.
Looking at some next steps for the project with our Family Veto study, we are hoping to investigate alternative stakeholder perspectives, including perspectives of ICU staff, organ and tissue donation coordinators across Canada, as well as the perspectives of substitute decision makers. With our health equity study, next steps for that project are to explore barriers and facilitators in accessing living donor kidney transplant for other ethnocultural groups. And we are currently embarking on a new project to investigate access to organ transplantation, as well as outcomes of organ transplantation for Indigenous patients in Ontario and Manitoba. I'd like to take a moment to thank our team and acknowledge their hard work and contributions. We have, as you'll see on this slide, a number of partners and collaborators, investigators who we work with, and of course the Anthony Lab, our students and members of our team. And thank you, Paula and Heather as well, for organizing the session today. And at this point in time, we're ready for some questions.
Thank you so much, Sarah and Gia, for that wonderful presentation. You know, I listened intently and am amazed by all the wonderful things you guys are doing at the lab. You know, all types of research is important, but you know, seeing some of those quotes on the screen, the qualitative piece, and you know, putting it all together and really talking about all the layers, because that's what it really is. There's so many layers to this this complexity of transplant and organ donation, and really getting you know, a culture or creating a sense of it being like norm. It is really truly amazing. So good work to you guys and all the team there that you have involved. But as you can see, Courtney has popped up the Slido. I will remind people, if they want to submit some questions, we still have some time. Please feel free to do so. Slido.com is the website you need to go to, and you enter the code organ donor, all one word, if you want to ask a question. So we'll jump right in, see how many we can get through while we have the last 10 minutes to clue things up. And the first one there on the screen is about your Family Veto project. And this person is asking, do you think that they'll get rid of Family Veto? And they made the comment, it sounds very disrespectful to the deceased. What are your thoughts on that?
Good question. That is an excellent question. And I feel like it is quite difficult with all the different stakeholders involved. As we mentioned, you know, we have the family, we have the deceased. And in the case of Family Veto, the deceased can't advocate for themselves. They are deceased. And also kind of the legal and the ethical lens that we can apply to Family Veto. I think really in terms of in our study, you know, the need for public education, and really a cultural shift in our views of organ donation and patient autonomy. And I think that really would be moving towards the right direction of addressing family veto and improving organ donation, and also respecting the autonomy of the patient even after they are deceased.
Yeah. Sarah, anything you want to add? I'm going to actually kind of tie the next question into this about the legal aspects. Gia, you touched on it, but there are definitely some legal pieces around this. And is there anything that can be done on the legal side of things to kind of protect that that person's wish to donate?
Yeah, and I think, you know, it's really, as Jai was saying, almost even creating that culture where the veto isn't necessarily something that is thought of as maybe even, you know, socially acceptable, or something that is thought of as an option is really quite important. I'm not really an expert on kind of the legal standpoint. It does get quite complex in that issue, and I think, you know, always important to be respectful of everyone's wishes at that time. But Jai, I'm not sure if there was anything you wanted to add there.
Yeah, I'm going to jump in a little bit on the legal standpoint. I mean, in Toronto right now, or in Ontario right now, I should say, you know, family veto, or one's registration to consent is legally valid consent, right? And that remains even after death. But I guess it is that kind of cultural aspect, right? Because even if it is illegal, or, you know, not according to the law, healthcare providers are not going to remove organs at the end of the day if families are not in support of it. I think there is kind of that kind of ethical lens to put on that too. So I don't know if you know, if changing, or like, you know, reaffirming the law, or kind of education of what the law is, could even change anything. If at the end of the day, it is that tension between families and healthcare providers, and even organ donation organizations.
Yeah, I think that's a good point. Oh, Samantha, are you there?
I am here.
Okay, did you want to jump in?
I was going to say, so the rates of family veto have been going down over time, and there have been changes made from Trillium Gift of Life in their wording to effective requesting, and that has made a big difference. You know, my opinion is probably we'll never see family veto completely eliminated, because there's so many different variables that go into that decision-making process. I think some of the recommendations, not so much from a legal standpoint, but a practical standpoint, is that you've told people that you have registered to donate, and you almost have, like, not necessarily a living will, but that someone can advocate for you when you can't. So you've told your family, friends, that I want to let you know that I have gone ahead and registered, and this is why I've gone ahead and registered, so that people are aware of what your wishes are, and can actually then, when the time comes, be there to state your preferences.
Yeah, that's a great point. And you brought up Trillium, and I was thinking, as you were talking about, we now see the Trillium messaging is not just sign up to be a donor, it's sign up and let your family or your loved ones know your wishes, which I think is that piece that's really important to kind of maybe, get everybody on board. So I think that's.
And when we did do the media analysis a few years ago, there were actually lots of articles about people asking this question: what can I do from a legal standpoint to ensure that my wishes are fulfilled? And there really wasn't anything kind of concrete at that point in time. Like you said, the recommendation was speak to others.
Yeah, absolutely. Very, very important. Let people know. Moving on to the next question. I think this is a great question. I think it's something that a lot of people ask. At least I know in my role as outreach coordinator, I get asked this all the time. What are some suggestions individuals can do to encourage both deceased and living donation? And I think the point Samantha just brought up was perfect. Talk to people, let people know. But are there other things that people can do as well?
I think
this. Go ahead, Sarah.
I think that's it, like really bringing this up in conversation. And, something that came up in Family Veto is regarding that is, is this dinner time conversation? Is this things that are coming up in a way that isn't maybe as taboo, or, you know, bringing it up in ways that just seem more normal. Even, you know, having conversations with your family doctor about what does this sort of thing look like, to kind of increase your knowledge as well.
Yeah, anything for you, Gia? No.
Nothing more for me.
Nothing more? Yeah, no, that's a great point.
Yeah.
Get rid of the stigma. Absolutely. I love this question. It said, and it's, I guess, in relation to the crowdfunding, so the fundraising study. Did you look at where in Canada the patients were from? Because people who live in remote communities probably are going to be in a situation where they need to raise money, relocate, travel, etc. Was there any way to figure out from those crowdsourcing, like those GoFundMe pages or whatnot that you studied, where people were coming from or where they were located?
And that's a great question, because really looking at kind of geographic area of study and even proximity to transplant centers as well would be able to provide some good information around that. We did look at province kind of where that campaign was coming from. And I have it with me here now, predominantly from Ontario, BC, Alberta, and then fewer campaigns for Yukon, PEI. It seemed to kind of follow population levels of different provinces. We didn't do kind of a further in-depth analysis of where specifically the geographical location and kind of proximity to a transplant center was. But again, something to think about with that would be that not necessarily all campaigns were specifically started by the recipient of the campaign. So some data might have differed there, but that's something that future research could look at for sure.
I was going to jump in as a clinician. So in my experience over the last 20 years, we actually see the most successful fundraising campaigns from families from the East Coast, from actually small communities. They have had incredibly successful either crowdfunding or different fundraising initiatives over the years in comparison to those from larger kind of urban centers.
Yeah, and I'm smiling. If you guys haven't picked it up already, I am from Newfoundland. So I come from the East Coast. And when I read this question, that's exactly what kind of triggered in my mind was, you know, people from a certain community or from a certain area tend to rally against, or rally together, should I say, when somebody's in need. So that warms my heart, Samantha, to know that that happens. And I'm not surprised, because the East Coasters are a very friendly bunch that take care of their own. So yeah, totally interesting and makes sense. But yeah, definitely future studies would be interested to see what would come out of that. Next question is, have there been any, again, family veto question, has there been any success of past organ recipients assisting coordinators in the process of obtaining consent from family members? So I think what Heather is asking is, you know, if you had somebody who's received, say, a liver transplant, and they come with the coordinator to speak to the family about the potential of donating their loved one's organs, is that something that could happen or might have, you know, a better chance of eliminating this veto aspect?
I'm actually not sure if they are doing this right now, or if they could. I'm not sure, Samantha, if you know much about past organ recipients assisting. I'm thinking of how it could impact decision making and whether it'd be kind of seen as coercion, maybe not coercion, but too much, maybe too much. They want to kind of provide it in the most objective way possible, and to make sure that, you know, families are the most informed. I don't know if Sarah.
You don't want anybody to feel pressured, like, oh, here's this person.
Exactly.
You should, yeah.
Exactly.
Yeah,
although I do think that, you know, if family members are interested in learning more, I think having a past recipient to kind of provide that firsthand lived experience to family members would be excellent in terms of information sharing.
Yeah.
I think it's a great question, a great idea.
Yeah.
I don't know the answer to it. I do know that within the, as Sarah mentioned, the high school outreach initiative, it always is a healthcare provider and a transplant recipient who do the kind of transplant 101 talk. And often, again, many of our pediatric recipients, adolescents, young adults who would go into the high schools. I think it really changes the idea of who are organ recipients in Ontario. So they're definitely, and that has been remarkably successful, those programs.
Yeah,
Yeah,
the life
yeah.
experience, the real lived piece. Absolutely.
Absolutely. And also I feel like the high school initiative program and other kind of initiatives or educational initiatives is a more upstream process or intervention in terms of like, at that point, family members already knowing, instead of, at that kind of very emotional time of trauma and death, kind of, it's a little difficult, more difficult, I feel like, to make that decision. But when you already know from having learned, and also if we have this kind of cultural shift of less stigma around death, then it is, I think, a more kind of upstream process.
Absolutely. We've hit the 1 o'clock mark. So that's all the time we have left today, but I want to thank you both for presenting, and for Samantha for attending as well. This has been a fantastic conversation. Thank you to the participants for spending the lunch hour with us. I hope you enjoyed the presentation as much as I did. I certainly learned some new pieces that really made me think about health equity and how we can really work through all those layers to really create a culture where organ donation and transplantation is at the forefront. So Courtney just put up the slide there. There is going to be a recording available on YouTube. So if you missed something or you want to check this out again, by all means, visit our YouTube channel. And then if you have any questions, if maybe you asked a question and we didn't get time to get to it, or if you go away and think of something later, by all means, please feel free to give us a call, email us, and we can certainly get the answer or put you in touch with Samantha or Sarah or Gia or whoever is best appropriate to answer that question. And as always, please feel free to follow us on our social media channels. We update them regularly and put all kinds of information about education sessions like this, as well as other important information out there. So thank you, everybody. Have a great day, and we will see you all soon at our next session. Take care.